Perfect.
Okay. Sorry, that's a good. Yeah, it's recorded. Sorry. Thank you, Bastian, for the reminder. So that's for the two inheritance patterns. So if we're talking about the screening, what is it then? Is it like identifying one carrier in a big group of people? Not really. Research has shown that everyone everyone is a carrier of mutations that can be linked to these conditions. So it's not 1 in 100 individuals that is a carrier. We are all carriers of these mutations, but we don't know because we don't develop symptoms or the conditions. It's, of course, not that relevant to know if you're a carrier yourself because it doesn't have any consequences for your own health. But if, for example, person A and B are a carrier of the same condition and they meet, they get together and they want, after a couple of months of years, start their own family, then of course there is an increased risk because they are both carrier of the same condition. And then for the autosomal recessive conditions, there is a chance of 25% each pregnancy that their child might develop the condition. So in Belgium, it all started in 2017 when the Superior Health Council published an advisory report. After that, the 8 Centers for Human Genetics got together and created a national working group. And the outcome of those working groups was the BeGECS. It stands for Belgian Genetic Carrier Screening. So it's a new offer that is available to all couples planning a pregnancy in Belgium. It's already available since the end of 2019. It's a pre-conceptional test offer, so it's only available to couples who are not pregnant yet. So it's not being offered during pregnancy, and it's only for like reproductive partners. So as an individual, you cannot get this type of screening. Of course, it's screening, it's not a diagnostic tool. So if you have a family or personal history for a genetic condition, it might not be enough. So there, a genetic consult still remains very important. So which conditions are included in the test panel? It's a very large test panel where more than 1,000 genes are being looked at that are associated with multiple autosomal recessive and X-linked conditions. So the majority is X-linked autosomal recessive conditions. The smaller part are the X-linked conditions, but they were included. So the test is right now there is no reimbursement, so couples have to pay themselves out of pocket, and it's 1,400 euros per couple. So it was decided to report the test results in 2 ways. So for the big part of the results, people will get a couple-based results. So there they will only be informed if they are both carriers of the same condition. So if one of both partners is a carrier, it will not be reported for these conditions. And of course, the X-linked conditions. So this means that the couple-based test results really show the increased risk the results for the conditions where there is an increased reproductive risk. For some genes, also individual results are being given, 7 genes. So there you get information. Each individual that is being screened gets that information also. Why? Because if you are a carrier of a condition, your siblings, for example, have also 50% chance of being a carrier. So this type of test reporting, like the individual test results, do allow also cascade testing to identify other carriers of that same condition in your family. But that's only available for 7 conditions. So we did some survey studies also, because of course it has been a debate among experts for a very long time. Should we offer this? How should we offer this? But little was known about how the target population in Belgium thought about this, how interested interested were they to have this type of screening, and how would they, if they were interested, how would they like to see everything organized. So we did a survey study in public pharmacies. We asked people that came by their pharmacy to fill out a survey on the spot. The idea was really to reach a very broad audience, not only the highly educated people, but really everyone, and to see how much interest was there, but also knowledge, attitudes. So I will be showing some of the first results. So what we saw was that a large group of respondents, of participants, said, yes, we would be interested to have this type of screening. 1 out of 5, a little bit more, were not yet sure. I think that's a very understandable result, because of course it's a new type of screening. A lot of people didn't know it yet. We did give some background information, but it was very brief. And the smallest group said no, but there were already people saying like, no, this would not be something that we would consider in the future for ourselves in the context of a child wish. So we also looked at attitude. So how do people evaluate this? So for this, we used 5 bipolar word pairs, and we asked participants to, on a 5-point Likert scale, to position themselves between the word pairs, how they would evaluate this kind of screening for themselves. Based on the answers, we calculated an attitude score, and this is the histogram of the score. So it was a score that ranged from 5 until 25. You see that a large group is more in the middle. We then recoded into 3 categories, which gave the following results. So the largest group had a quite positive attitude towards expanded carrier screening. The middle group, it was also quite a more neutral attitude, and the small group had a more negative attitude. Then for knowledge, we developed also a new knowledge scale to assess what people already know about this. It were 14 questions, and these are also the results. So the score ranged from 0 until 14. Majority had a high knowledge score, which means that they answered at least 10 out of 14 knowledge questions correct. The middle group was moderate knowledge level, and the small group was low. So we did provide some background information. This could have influenced also their answers. So this gives quite positive results. But we did see also, if we looked at the more knowledge questions on an individual basis, that some knowledge questions were really answered less often correctly than others, and in particular those with the inheritance patterns and the risks that it gives. So I think it's still important to take this into consideration if you're thinking also about how people should be informed, how they should be counseled, because I once got the comment that, do people really need to know all this information to make a decision? If a doctor prescribes an MRI, we don't expect people to understand everything either. But this is, of course, a different situation, because you really want couples to make an informed decision that is in line with their own values, because of course it can have a major impact also when you get a test result back, because then you might be also faced with a choice that you have to make in a reproductive context if you still have a child wish. So I think it's very important that people understand what it is not, and if they decide to do it or not, that it is really like an informed decision. Some practical aspects, of course, are also being discussed, and you hear different opinions on this. So one of the aspects that we have to consider is when to offer this. Do we have to offer this through healthcare providers? At school already during reproductive years? It's not easy to really reach the target population, like couples thinking about having children. Most of the times those couples only reach out to healthcare providers when they are already pregnant and for the following follow-up. But yeah, of course, here you want to reach couples before pregnancy, because then these couples also have more reproductive options. But it's interesting also the research that we have done and the interviews that I'm also doing right now to learn also from people in the general population, not from experts, how they would like to see this organized, of course. And another big elephant in the room is also the price, the cost. Right now it's 1,400 euros per couple, so it's out of pocket. There is no reimbursement, but of course this is quite high price, and it can also influence the decision of people to do it or not. So this is also something that is quite interesting to get the opinion of couples and individuals in the general population. So that is also something we assessed during our survey study. So we asked people if they would be willing to pay out of pocket. So a large group said yes, 10% said no, but again, 1 out of 5 participants were not sure if they would be willing to pay. So I think there maybe there's more information that they need to make this decision. But it's again a quite interesting result also. We also asked the amount people were willing to pay. We didn't specify the actual price, but we saw that a lot of people were willing to pay a certain amount, but not that many were really willing to pay the actual price. So I think this is something also important that, yeah, of course, it might not be very easy for people to like understand the value of this kind of screening and the price that it might cost. So I think it's also something we are looking at right now, how we can study this further. But of course, it can have also a major influence on the decision of a couple. If the price is the reason why they decide not to do it, I think that should be prevented. So we did survey studies to get this information, but we also performed an implementation study where we offered the carrier screening test to couples. So just to give an overview, we recruited in a gynecologist practice, so women who came for a consult who were Dutch speaking and were not pregnant. Were informed by their gynecologist about the fact that the study was running and were invited to answer a first survey that was anonymous. And if these women showed interest in expanded carrier screening, they were asked to leave contact information and were recontacted by the researcher afterwards. So they also could discuss, of course, the offer with their partner. The second time point, so those couples that were interested to participate in the study were invited for a Priestess counseling session where we really explained everything again, where there was room for questions, and if those couples decided to get themselves screened, we took the blood samples and they were asked to fill out a second survey. Then at the third time point, we gave back the test results, of course, and afterwards we also asked people to fill out a third questionnaire. There it was really about the understanding of test results, of course, but also how they did experience the whole process and everything. And we also are performing at the moment also interviews with these couples that chose to get screened. So it's still ongoing, but just to give an idea, in total we had 127 who were referred by their gynecologist to the researcher. a total of 41 couples participated in the study. Due to Corona, we had to stop the recruitment at that number. We wanted to have more couples, but unfortunately, it has not been an easy year also for the recruitment. So we are analyzing these results right now, and we already got back also 58 questionnaires at time point 3, so the last ones. 2 couples still have to get back their test results, so it's still ongoing. And of course, there is some dropout, but I hope they will still send them in. And the interviews are also being performed at the moment. So. So what we see is that not all couples that were being offered a carrier screening test, also in the context of the study, it was free, so they didn't have to pay themselves, went through with it. So there were a number of reasons that they stated. Sometimes it was not the right time, partner was not interested, or like they said, like, yeah, we don't have time right now, but yeah, or we don't have a very active child wish right now. So there were a lot of reasons. Also, some women got pregnant, so were excluded from the study because it's a really preconceptional offer at the moment. So only 1 out of 3 plus approximately did participate or did accept the carrier screening offer. And the test results. So this is what we found. So there was 1 couple out of the 41 couples with an increased risk. It was for hemophilia A. So there the women it's an X-linked condition. So the women was a carrier. So it's 2.44% of the participating couples. And we identified also 10 individual carriers for those conditions that were reported on an individual level. So it were 7 women, 3 men, just as background information. So there we have 12.2% of participants that were identified as individual carriers. So this information, of course, in the reproductive context is less valuable, but can be interesting to share with siblings or other family members. So I don't know if there are any questions already from the audience. I also put some discussion points up, but maybe I first have to ask if you have any questions for me already.
Yes, Eva, I have a question. Jeroen Luiten here.
Yeah.
Thank you for the nice presentation. I was just intrigued by what you say, 1,400 euros for a test, and people who do it, they have no idea whether they're carrying a certain malfunctioning gene, or so it's asymptomatic. So I'm surprised because it's still, yeah, it's quite a lot of money. So do you have an idea who are these people who were willing to spend 1,400 euros for some hypothetical problem that will probably occur in very small probability, and so on? So it must be a very select group of people who do that. Or do you have any ideas on who are these people?
Yeah, so the survey that we did, of course, it was a hypothetical question. I think if people would have known that the test was 1,400 euros, I think the group that said yes would be much lower. We did identify some factors that influence this. Education level is amongst them, and couples who still have an active child wish also said they would be willing to pay more. But of course, the price, it's very interesting because, of course, in the study, in the implementation study, we offered it free of charge, but I'm doing the interviews with the couples that participated right now. And if I ask them, like, would you have done it if you had to pay those 1,400 euros, they all say no. So we do have to look more into that. I think because of course, yeah, it's hypothetical and we didn't specify the actual price to the participants in the survey studies, but yeah, it has major implications also. Yeah.
But you have no idea about in real life who are the people who actually pay that money?
No, for now, the test is available since like end 2019, but right now in Belgium, not that many couples know that it exists. There hasn't been a big campaign about the fact that it is available. Most couples that have been doing the screening test are couples that are starting a fertility treatment, that have also a quicker access to the reproductive options also that are being proposed to carrier couples. So I think, yeah, mostly them. And of course, yeah, if you already have, that is something that we do also see in the results. If you already have a genetic condition in the family, those people are also more willing to pay for this type of screening or to engage. Yeah.
Okay, thank you.
Yeah, you're welcome. Any other questions? Or comments? Things that came up while listening to the presentation?
Well, then I have a second one. If you say that the price is 1,400 euros, do you know any? I have no idea, but is there anything going on in terms of reimbursing this? You know that the government is, because obviously if you manage to save on later treatment costs, it could be good investment for the government as well. Is there anything going on that level?
To my knowledge, not at the moment. No. It's still quite small. They haven't rolled it all out on a bigger level, so not at the moment. At the moment, nothing is on the table for getting a reimbursement. But of course, if you see like the NIPT, the non-invasive prenatal screening, it went also very fast. So I'm not saying that it's not possible that it should or could be the case in a couple of years, but at the moment it's not on the table yet. No.
Okay.
I also have a question. Eva, thank you very much for your presentation. I was just wondering, why did they choose to report back the individual carrier statuses for these particular 7 genes?
Yeah. So those genes were really selected on the carrier frequency. So it's all pretty rare conditions, but some are more prevalent than others. And it was really the carrier frequency that was the criteria that they used to select those 7 genes. So there's SMA, but also cystic fibrosis, for example, because there are still rare, but they do occur more often than the other ones. So that's why, because then you also can offer cascade testing for these conditions.
Okay, thank you. Yeah, because I was thinking, if you only do it like in pairs, so it's also might be a bit of a waste, right? Because if you break up or whatever, you have to do it again, basically.
Yeah, that's true. That's one of the reasons that people are more in favor of individual test results. That, of course, nowadays people do break up and might have a future child wish with someone else. But on the other hand, in the field of genetics, they do find new mutations or new discoveries each year. So I think the test that they are using now in 5 to 10 years might not be the same test that they will be using in the future. So that might also have as a consequence that the person who has been screened should do also a new test. And yeah, just to give an interesting case, also last week we had already a cases in our study where we had how do I say that? So one of the carriers that was identified in the study already had not a problematic situation, but information was shared by someone else to family members, and yeah, it already created a little buzz in that family. So that is also something we have to take into account when we give individual results. It's not only impacting the people who chose for the screening, but the whole family, of course. And that is something you can ask, like, is this really the goal of this type of screening? Okay. Any other questions?
Yeah, I have a question. Hi, Eva. Thank you for the presentation. It was very nice as always. I wanted to ask, you said that there's been like people that decided, indicated that they would have wanted the test and then decided not to take it. Do you have an idea why?
Yeah, I try to also get more information, but of course it's a scientific study and people are not always are not obliged to say why they don't participate. So that's a little bit the thing that we struggled with. But when I called them back after they first gave me their contact information because they were interested, most people automatically did state a reason, and most often it's because the partner is not interested or doesn't want to know, or it's not the right timing, or they're became pregnant or are thinking about becoming pregnant in the near future and then don't want to do it. So I did try to get also this information, but I think it would be interesting if we can do a more in-depth study on why people are declining, because I think some people also say like there's nothing in my family, so why should I do this? But if as I've shown with the family tree, of course you can be a carrier without any genetic condition, any like patient in the family that has the condition. So it would be interesting. I totally agree with that, to do more in-depth research on that.
Yeah. And the same for compared to the parents who had a child with genetic condition that they didn't know they were a carrier for. You said that they all said that they couldn't have done the test even if they knew about it. And why?
No, so what I said, like those that didn't that wouldn't have chosen the test were the ones that participated in the study, and the test was free of charge. So if they had to pay themselves, they would not have done it. They did participate because it was also being offered for free in the study. That was also a factor that influenced their decision. But I didn't specify this in the presentation, but we also did an interview study with couples who already have a child with an identified genetic condition. And there you have really two voices. You have parents who said like, yeah, if this would have been available, of course I would do it. Like, because it's not that I don't love my child, but it has a major impact. And other parents are like, yeah, but of course, because not all conditions can be identified. There are still conditions that can occur during conception, where parents are not a carrier of the mutations or a newly developed mutation within the child. So you cannot screen for everything. So couples who had a child with de novo mutations, a new mutation, also said, yeah, but even if I would have done this type of screening, we would not have been able to prevent the birth of my child with the condition that it has. So then why do you do it? You cannot control everything. So there you really hear like, two voices, and it's quite interesting also. And I think it really depends on your personal values also, and what you really feel yourself. And your experience.
Thank you.
You're welcome.
I think, Eva, it's maybe a good time to move to the next presentation, but thank you so much for sharing your work with us. And I'm sure that if anyone has any questions, that they are probably free to contact you to move the discussion to a more private session. So now we have Maria José, who will tell us something about her Inspire projects in Basel, Switzerland.
Yes, thank you so much. I will share my screen now. Can you see it now?
Yes, we see it, Maria José.
Okay. Thank you so much. So thank you for the opportunity to share with you the INSPIRE project, which is the implementation and evaluation of an integrated community-based model of care for senior citizens in the canton of Basel-Land in Switzerland. So I would like to start by giving you some information that probably you already know. That we know that the population around the world is aging, and especially here in Europe. But most of these older people have a lot of chronic conditions at the same time. And it means that these older adults will require the support from different health and social care providers. But what happens most of the times is that these services are not well coordinated. And it means that these older adults are at high risk of suboptimal care or contradictory medical advisors, polypharmacy, and it also increases the risk of these older adults to be admitted to hospitals, to nursing home admissions, or even to die. So considering this, the canton of Basel-Land, which is a canton in the German-speaking region of Switzerland, created on 2018 a new legislation, the APG law. According to this new law, the canton of Basel-Land needed to be reorganized in 8 care regions. And in each of these 8 care regions, there was the need to develop a care concept for home. Oh, sorry, can you still see my screen? Okay. Okay. A care concept for home dwelling older adults. And in this care concept also, it was the need to create an information and advice centers. So the canton of Basel-Land contacted the Institute of Nursing Science of the University of Basel and requested the support to help them to develop this care concept for these information and advice centers. And this is how the INSPIRE project started. So the aims of the INSPIRE project is to develop and implement an integrated community-based care model for frail home-dwelling older adults in the canton of Basel-Land. And also we are going to evaluate the impact of this care model on patient and service outcomes. The INSPIRE project is a multi-phase project which was designed following the recommendations of the MRC framework for the development and evaluations of complex interventions. Our project consists of 3 phases, and I'm going to describe each of these phases. During the first phase, which is the development of the care model, we started by looking at the evidence that exists regarding to integrated care models for home-dwelling older adults. And then we did a systematic review and a meta-analysis where we included 19 different studies. And among the main findings that we found in this systematic review is that there was inconclusive evidence about the effectiveness of these integrated care models, but also the evidence was of low quality. Additionally, something that was very important is that many of these studies didn't include elements of implementation science during the development or the evaluation of these type of interventions. Besides this development, systematic review, we also conducted a contextual analysis to understand the context where we were going to implement our intervention. For doing this contextual analysis, we used different surveys. So in 2019, we conducted a population survey with the older adults of the canton of Basel-Land because we were interested in knowing their needs and preference about care, and also the future needs about care. Additionally, we have several meetings with different local and cantonal stakeholders, and many of them were representatives of care organizations or authorities, local authorities, etc. Additionally, we use different implementation science frameworks to conduct the contextual analysis and also to identify the preliminary implementation strategies that we are going to use in the next phases. So as results of this phase number 1, we developed the Inspircal Model, which consists of 4 main components. It starts with the screening of older adults who are at risk of being hospitalized or institutionalized. Then we will conduct, a geriatric nurse expert will conduct a comprehensive geriatric assessment, and this geriatric nurse will work in coordination with a social worker. This comprehensive geriatric assessment is going to be conducted in the information and advice centers. After this comprehensive assessment has been done, there's going to be an individualized care plan is going to be developed. And also, this individualized care plan is going to be discussed with the older adult, the informal caregiver, and the external care providers such as the GP or the social worker or any other professional who is involved in the care of the older adult. Additionally, the nurse and the social worker will start with the coordination of care with these external care providers. And finally, a follow-up is going to be done based on the needs of the older adult. Additionally, in this phase number 1, a logic model was created. This logic model helped us to plan the implementation of the intervention. As you can see here, we have different columns, and in the first column, we included all the resources that we will need to implement our intervention, which is here in the second column, and also the outputs that we expect after the implementation of our intervention. Additionally, in this logic model, we included the different outcomes that we think that we will get after the implementation of our intervention, and we classified them according to the time when we expect that they are going to change. So by defining these outcomes, also we knew which outcomes we were going to include during the evaluation of our intervention. The phase number 1 is already completed. So now we are going into the phase number 2, which is the feasibility assessment of our intervention. During this feasibility assessment, we are interested in assess the feasibility, the appropriateness, the acceptability, the adoption and fidelity of our intervention. And also we would like to explore the perceptions and the experiences of the older adults, the nurse and the social worker who works in the information and advice centers, and also the external care providers who will be working with us. So this feasibility study is going to be a mixed methods study, and we are going to use a convenience sample of 15 older adults of 75 years and more with a chronic health frailty index of 4 or more. And we are also going to have some interviews with the nurse and the social worker and the external providers. So this is how we had planned to collect the data for the feasibility study. We are going to use a fidelity tool to measure the fidelity to the core components of our intervention. And also we are going to have bi-weekly meetings with the information and advice center nurse and the social worker. Additionally, we are going to have interviews with older adults, and we are discussing now if we are going to include the informal caregivers, because we know that these older adults with chronic conditions most of the time rely in the support of informal caregivers. So for us, it's also important the perceptions of these informal caregivers. But yeah, we are still deciding if include them or not. And finally, we are also interested in understanding the barriers and the facilitators for the implementation of our intervention. So we will use the NOMAD survey. This NOMAD survey is based on the normalization process theory, and we will send this survey to the external care providers. So after we finish this feasibility study, during this feasibility study, we will see also if there's any other implementation strategy that is needed to go into the large scale implementation, or if there is the need to make some small changes in the intervention that we would like to evaluate. So once we finish the phase number 2, we are going to go into the phase number 3, which is the evaluation of effectiveness. So during this evaluation, we are not only to evaluate the effectiveness of the intervention, but we are also interested in knowing if the intervention worked or not, and why. So for the effectiveness evaluation, we are interested in knowing how this integrated care model affect the level of person-centered and coordinated care. That's our primary outcome. But also we have selected some secondary outcomes at patient level and also at service level. At patient level, we have choose some outcomes such as functional decline or treatment burden or symptom burden. And at service level, we included outcomes such as nursing home admissions or hospital admissions. So for doing this effectiveness evaluation, we are going to conduct a prospective pre-post cohort study with a hybrid type 1 implementation effectiveness design, because we are not only interested in evaluate the effectiveness of the intervention, but also we want to gather more information about the implementation pathway. For doing this effectiveness evaluation, we are going to use a convenient sample of 77 older adults of 75 years or more with a chronic health frailty index of 4 or more. And here we are going to also have interviews with the informal caregivers. To measure our main outcome, which is the person-centered and coordinated care, we are going to collect quantitative data, and also qualitative data. To measure the quantitative data, we are going to use the person-centered and coordinated care questionnaire. And we are going to send this questionnaire to the homes of the older adults at baseline 6 and 12 months. And we are also going to have these interviews with the older adults and the informal caregivers about their perceptions of person-centered and how this intervention is helping them with the coordination of care. For measuring the secondary outcomes at patient level, we are going to also use a paper-based questionnaire, which is going to be sent to the homes of the older adults at baseline 3, 6, and 12 months. And for measuring the secondary outcomes at service level, we are going to use the information that we can get from the patient file at the Information and Advice Center. But as I mentioned to you before, we are also interested in knowing why our intervention worked or not. And therefore, we decided that besides the fidelity, besides measuring if all the components of our intervention are being implemented according to the protocol, we are also interested in knowing if our intervention is being normalized in the external care providers that are working with us. So for doing this, we're also going to use during this phase the NOMAD questionnaire, because we are really interested in understanding if our intervention is being embedded into the routine of the external care providers that are working with us. While during all this time that we have been trying to implement our intervention, we have seen that the main challenge of our intervention is the coordination with the external care providers. So for us, and for the successful implementation of our intervention, we see that this is crucial to understand if our intervention is well received in the external care providers, and how this is being part of the routine of these external care providers who are working with us. So we are going to send these questionnaires online, and we are going to send it at 3, 6, and 12 months. Additionally, we are going to get some information about the use of primary healthcare services by sending a service to the older adults. Here you can see all the outcomes that we are going to measure during the phase 2, the feasibility study, and also during the phase 3, which is the effectiveness implementation and evaluation. The next steps for our intervention is first that we are going to continue with the local and cantonal stakeholder involvement. As I mentioned to you before, for the successful implementation of our intervention, it's really crucial that we keep talking and discussing with them, and also engaging them more in the implementation of our intervention, because in this intervention, which is based on a community level, it really requires of a good collaboration with other care providers. So for us, this is something that we are putting a lot of effort. All our team is dedicated in this. So we are doing this at this moment. And we are hoping to start with our implementation with the feasibility study in one care region on September of this year. And once this feasibility phase is finished, we will start with the effectiveness evaluation. So for concluding, I wanted to highlight that integrating implementation science components in a project like this can probably increase the likelihood of successful implementation. And also that by using hybrid designs will speed the implementation of integrated care models into real-world settings, because the evaluation will provide insight of the effectiveness of the model, but also of the implementation pathway. And also something that I think this is something that I have learned during the last year is that when we are conducting this implementation science project, we need to be prepared for adaptations because everything can change. And as I mentioned to you, this project, which is going to be implemented in the community, really requires a good collaboration with other care providers. And if they are not working at the same pace with us, or if they don't agree, this can be a huge problem, and it will need for us to make some adaptations so we cannot keep doing the same things as we thought we would do. So yeah, I wanted to ask you now if you have any questions. I will be more than happy to answer.
Marie-José, I
Yes.
have a question. Thank you, by the way, for the very nice presentation. And you seem to have a lot of evaluation work going on, so it's very impressive, the amount of work that you're going to do. I was a little bit surprised by your sample size. It seems, I assume 77 persons per group. So 77 in the before measurement and 77 in the after measurements, but it seems a bit low to me. Can you maybe elaborate on why you arrived at that number? Do you expect to have a really large benefits on your primary outcome then?
Yes, because we expect to have a change in 2 points in the person-centered and coordinated questionnaire that we are going to use. So therefore, we calculate that sample size.
Based on scale, and what was the scale actually? Because I don't really, I think it's an interesting primary outcome to focus on the person-centeredness, but I've never heard of it. Can you maybe explain it a little bit?
Yes, this is a tool that was developed like 5 years ago, I think. This tool has 11 questions, and this tool, the person-centered and coordinated care experience questionnaire, assess both items, the person-centered and also the coordination of care. So the idea is that we are going to use this at baseline at 6 and 12 months. And yeah, we would like to see the changes after the intervention. So that's why we are going to also use at baseline. So we would like to see after 6 months and how it changed after 12 months.
Thank you for the explanation.
And something that I would like also to mention is that, yeah, this project seems to be huge. This is why there's a lot of people involved in this project. We are 3 PhD students working on this project. And also we have the collaboration of other members of the Association of General Physicians in Basel-Land, and also the Swiss TPH, and yeah, other institutions. And also we have many funders, and yeah, I think this is something very important to highlight, because many people, when they see this project, they think it's huge, and yes, it's huge, but it's because we are some people working on it.
Indeed, a lot of work. I think if there are no further questions, that we can end the session. But I think, Marie-José, if anyone has any questions later on, they'll probably feel free to contact you as well. Or if they want to learn something about the hybrid effectiveness implementation, I think you would be a very good contact, because it's interesting work that you do. So Eva, Marie-José, again, thank you for presenting your work to us today. Thank you to all who are here with us today. I hope that you enjoyed your lunch and these presentations. For the future, we are still planning seminars on 3 different dates provisionally, but we are still looking for speakers to fill up all the slots, and if we have that, we will send new invites to you. So those will be sent by Pascal via email, as is the usual way. I think that's the most important thing to say. So thank you for being here, and I hope that you enjoy the rest of your day. Bye.
Thank you.
Bye.